All right, guys, we're going to get started with our next speaker. So thank you again to Dr. Mark Su. And then next speaker is Dr. Brian Wright, another double graduate. Dr. Wright graduated SUNY Downstate Medical School, as well as the Downstate School of Public Health. He has fond memories of C1 and CCT in the fast track, the asthma room, and the APOD, and a member of the Kings County Downstate EM GOAT class of 2008. I know that's a much disputed title. He completed a critical care fellowship at North Shore, and for the last 7 years has been maintaining the SUNY tradition at SUNY Stony Brook out on the East End in the ED resuscitation and critical care unit and the neurocritical care ICU. He loves resuscitation, ultrasound, and neurocritical care. He is a clinical associate professor of emergency medicine and the current director of the Stony Brook Emergency Medicine Advanced Resuscitation Training Program. And he's going to speak to us today about emergent stroke management. So thank you, Dr. Wright, for being here.
Thank you, James. Thanks a lot. I gotta follow Dr. Su. That's awesome. All right, if anyone just tell me if you can't hear me. But thank you so much for having me on. You know, I'm super proud to be here, and also super proud of all you guys for the hard work you've done over the last years and months. And thank you for having me. Today I'm going to be talking to you guys about the Acute Ischemic CVA for EM physicians. This is a really big topic. So what I'm really going to be going into, is spending a lot of time on how you can use sort of, just go beyond non-contrast head CTs and use advanced neuroimaging like CT Angio Perfusion and MRI to sort of help you take care of your patients. I'll have basically two talks wrapped into one. The first one regarding like LVO, large vessel occlusions, and the second one regarding TIE management. We'll go briefly into clinical prediction rules, and if we have time, we'll also talk a little bit about the TIE workup. So I always like to start my neuro talk sort of with a story of hope, and sometimes every day in the emergency department can feel like a battle. We're constantly sort of weaving around obstacles and sort of, taking punches, yet every day we still respond to that next bell and still, get up for our patients. And we do that sort of, I think, to really, make a difference in their lives. And nowhere is that more apparent than in neuroemergencies. And it's, it's important to always have hope and to always keep fighting. And you'll be surprised with the amazing things that you can do for your patients. Let's start off with a case. Let's start with a 56-year-old right-hand male with a history of diabetes and AFib. He wakes up with right side weakness and aphasia. His NIH is 15. And you're concerned that he's got a CVA. You're not quite sure if it's an ischemic CVA or if it's a hemorrhagic CVA. So you get him to the CAT scanner pretty quickly. And here's his non-contrast head CT. And there's no intercerebral hemorrhage. But if you look closely, you can sort of see the beginning of something going on here on the left side in the MCA territory. And if you look at the caudate and the basal ganglia internal capsule, this looks a little bit hypodense over here relative to the right side. If you look at this insular cortex here, this looks a little bit hypodense as well. So you're concerned that this patient has an ischemic stroke. So what are we going to do for this patient besides, supportive airway breathing circulation? So his last known normal was last night. So we know he's not going to get TPA. Is there something else that we can still potentially do? So the answer is he might be a candidate for interventional therapy. So how are we going to determine that? So let's talk about using CT angio and perfusion to guide acute stroke therapy. So the quick overview is that I want you to take a really a stepwise pattern to look at it. And this is how I do it. So the first thing is you want to take a clinical guess. So this patient has right side weakness and aphasia. So I know that I'm going to be primarily focusing my eyes and my attention on the patient's left side. I'm going to look at the perfusion first. So I'm not going to jump right to the angio. I'm actually going to look at the perfusion first and see if there's any perfusion deficits. On the perfusion, I'm gonna look at my mean transit time or my Tmax area to see the area at risk. Then I'm gonna go back and look at the cerebral blood volume to look at the actual infarct. And I'm gonna take the difference of those two to see if there's any penumbra and to see if there's anything that can be angioed. So after I look at that, I'll look at the angio, and if there's a penumbra and a lesion on the angio, then I'm going to call my interventional radiologist for interventional therapy. So let's look at our case. This is my patient's CT perfusion. So if you look here on this side here, this is their mean transit time, and we see a irregularity and a increased transit time of flow here in the left MCA distribution. And if you look here on the right, we see a corresponding decrease in blood volume here on the right that basically overlaps the entire area of tissue. So what does that mean? That means that this patient has, unfortunately, an infarct, and that's an entire infarct, and there's very little penumbra. The difference between the mean transit time and the blood volume will give you the penumbra. And when you look at this guy's CAT scan, you can see the right MCA looks good, but here on the left side, the left MCA has this acute cutoff here, and there's no blood flow. So is this someone who we can give interventional TPA for? No, based on time and CT imaging. Is this someone who can go to interventional therapy for salvage of a penumbra? Well, there's no penumbra. So unfortunately, this patient could get neither. What this patient did get is they got admitted to the neuro ICU. They got hypertonic therapy. And then the next 12 hours, they proceeded to swell and herniate, and they got a decompressive craniectomy. And they had a very prolonged ICU stay, and this was a very disabling illness and disease course for this patient. Compare that with my next patient, a 79-year-old male with Parkinson's, AFib, coronary artery disease, hyperlipidemia, and depression. Also presents with aphasia, altered mental status, and right side aphasia. His last on normal was 1 hour prior to arrival, but his NIH was 25. Here's his CAT scan. Caudate heads look good. Internal capsule looks good. Maybe a little bit of haziness in the insular cortex over here. Let's go to his. So he was on blood thinners, so he was not a TPA candidate. Sorry about that. And let's look at his imaging here. So on the left, we see our mean transit time here. And again, we see a similar left MCA lesion. But here we look at the blood volume. And in this situation, the blood volume actually looks pretty good. We see symmetry and we see good sort of values here. So as opposed to the first case, this patient has an almost complete penumbra of their left MCA. Going back to the CTA, now we know that we're going to focus on the left MCA distribution. And again, we see a cutoff here in the left MCA. This patient was taken to the Angio suite emergently, and they had a thrombectomy, and they got good blood flow. They left the ICU in a day and went to rehab, and 3 months later, they were back in their garden, living their life. So the name of the game is large vessel occlusions, LVOs. And how can we pick these out? Because these are therapies that are, these are patients that have basically proximal lesions of the major blood vessels going to the brain. These are devastating strokes. These are strokes that have a lot of territory of brain at risk. And if they're, in addition to being devastating from a morbidity standpoint, if they're large enough, these strokes can swell and cause herniation and death. A typical type of LVO is the MCA, and what is also known commonly as a malignant MCA syndrome. And these are large vessel occlusions of the ICA, the proximal MCA, MCA combo lesions. They're associated with a lot of basically cell death, ischemia, hemorrhagic transformation. Classically, they get edema from the 2nd and 5th day with herniation, although I've seen it happen earlier than the 2nd day, and they're associated with a very, very high mortality rate. So your goal in these large vessel occlusions in ED are to first, besides sort of supportive care, is to determine if they're candidates for thrombolytic therapy and or interventional angiography. I'm a bigger fan, obviously, of interventional angiography than pushing thrombolytics in these patients. And the second thing is, if they're not a candidate for reperfusion therapy, are they someone who needs decompressive hemicraniectomy, or are they someone who will need either medical management or palliative care? So how do you predict LVOs before the scans? And these are important if you're an EMS director, or if you're sort of routing patients to bypass primary stroke centers in favor of comprehensive stroke centers, or if in your institution you're trying to decrease your door to balloon times for strokes, akin to what was done in cardiology and STEMI a decade ago for cardiac cath. So there's a few clinical scores that we can sort of talk about, and just LVO strokes are obvious strokes, right? They're clear strokes. They're not, oh, I got a little bit of numbness on the side of my face for a few hours. That's not going to be an LVO. Sort of the big strokes that you can sort of see from across the room. Those are going to be the LVOs. But what are some scales? So the first one that I like to use is the LA Motor Scale. And that looks at face for droop, arm for complete strength, drift versus plegia, and grip for complete strength, minor grip, and not able to grip. And the higher your score, the greater your chance of an LVO. So a score of greater than or equal to 4 equals an LVO. Some places like to use LA Motor Scale and add aphasia to it as well. A similar type of score is the VAN score that uses weakness. So if you have weakness, then you go on to looking at their vision, looking for aphasia or neglect. If you have weakness or any of these other deficits, then it's possible that you have an LVO, and you should proceed with either taking directly to a comprehensive stroke center, or getting ready to activate your interventional team. Other institutions use an NIH greater than or equal to 6. And some places CT and Angio do CT angio perfusions on everyone. Now, my site's probably in the sort of the lower CT angio perfusion on everyone, but also like not really, everyone. Sort of think about, the recent trials and showing benefits for LVOs anywhere from 6 to 18 to 24 hours. And that's who I'm sort of thinking about. So who do I think interventional therapy is going to, to benefit on? So if you have a high NIH, you have a LAM score positive or a VAN score positive, up to 24 hours, I will consider, I will probably get a CT angio perfusion on you to see if they're an interventional candidate. If you have isolated aphasia, I will probably get a CT angio perfusion on you. Other stuff like, just paresthesias and facial groups, I'm not going to angio perfusion, but pretty much, everything else I'm going to have a low threshold to. And that's also going to depend on your shop and your interventional therapist and what they are willing to go after or not go after. My team's pretty aggressive and will go after some pretty distal lesions. So that sort of reflects my approach. Right. So how do we use CT angioperfusion to select for patients that are candidates for revascularization? All right, so let's talk about the penumbra. And that's sort of the goal and what we're trying to salvage. So if you remember back to physiology, there in stroke there's this core infarct then unfortunately, no matter what we do, that brain tissue is gone. That brain tissue is dead, and there's nothing to do to sort of save that. On the other end is this area of benign oligemia where the blood flow is decreased, but it's not decreased in such a way that will harm that brain tissue. And in the middle is this critical penumbra, and that's what we're sort of fighting for. You know, the blood flow is decreased, and it's decreased to a point where that brain tissue is clinically silent. So if you were to examine the patient, that corresponding area of the body would not respond. However, that brain tissue is not dead yet. Okay, mostly dead is still a little bit alive, right? So that brain tissue is still alive, and if you can get that tissue reperfused, then that tissue can come back, and that tissue can survive. However, as the sort of time goes on further and further and further, that infarct core will extend into penumbra, like sort of sand slipping through the hourglass, and eventually that tissue will be gone. So this is why it's important, to maintain good, ABCs, good hemodynamics, and also why it's important to get rapid reperfusion if possible. All right, so key concept, looking at CT perfusions. So again, the first thing you want to look at is either the mean transit time or the Tmax, and that will depend on your systems and which is better. Last year in my system, it was a lot easier for me to see deficits on the mean transit time. Now it's easier to look at the Tmax, so it really will depend on your systems. So just as it sounds, the mean transit time is the time it takes for the blood to get into the tissue and the time it takes for it to get out. And obviously, if it takes a longer time, that's going to be ischemia. So looking here, we can see a mean transit deficit here, a Tmax deficit here. So the mean transit time will tell you the area at risk, and then you're going to look at the cerebral blood volume. Okay, that will tell you the infarct size. And if there is small infarct relative to the area at risk, that is a penumbra, and that is a patient who will benefit from interventional therapy. So this patient here has a pretty decent sized area of ischemia, but if you look at the cerebral blood volume, it is increased or normal. So there's very little infarct, and this is someone who will benefit from reperfusion therapy. Contrast this with this patient here, who again has a mean transit time deficit on the left, but when you look at their blood volume, the blood volume now is down on the left. So this is a patient with a very large infarct core. And you can go in and reopen that blood vessel, but unfortunately that brain tissue is already gone. And you're just going to expose them to risk of reperfusion injury and hemorrhage without benefit. So again, comparing our two cases, the first case, mean transit time is very, very, very similar in both cases, right? You see the left MCA looks like it's out on both sides with a prolonged mean transit time. However, the key is in the blood volume. And in case one, you see the blood volume down almost entirely in that left MCA distribution on case one, where it's entirely preserved. So case one, no penumbra, case two has a penumbra. And that's why there was, we were able to intervene in case two and make a difference. So the good news is that there's a lot of AI, sort of artificial intelligence and computer programs that are now doing this for us. So one such example is the RAPID program, which I have at my shop. You may have something similar at your institution or where you're going, where the computer will actually just will do this for you. So sort of looking at this, this is a similar, RAPID to what my patient one had, where you see basically the Tmax. So this is your area at risk and your infarct core, and they overlap. So there's essentially there's no penumbra here, as opposed to second case on the bottom. This is your area at risk, and you see very little infarct here, and will give you the mismatch volume and the mismatch ratio. And this can help you determine the size of the penumbra and who who would benefit from interventional therapy. And this is just one criteria from one study. And again, I think it's going to be very dependent on how aggressive your interventional radiologist or neurosurgery team is. And, I think they're doing a lot more and more of these procedures because we're finding that even salvaging smaller and smaller numbers are beneficial for overall patient outcome. So my LVO takeaway points, use your LAMS advanced score for pre-hospital triage. I think in this day and age, liberal CTA perfusion for patients who could be thrombectomy candidates. Look at your perfusion studies before you look at the angios. Your mean transit time, your Tmax will give you the area at risk. Your cerebral blood volume will tell you infarct size, and those with a favorable penumbra are candidates for interventional therapy. And I'll save questions for the end. Going quickly through TIA cases. Next case, a 55-year-old male comes in with left arm weakness and numbness. He arrives to the ED 30 minutes later. His symptoms are dramatically better. He denies any headache, nausea, vomiting, chest pain, or other visual disturbances. His past medical history is as such, and his vital signs are a little hypertensive, but otherwise pretty much okay. He's got a very subtle pronator drift, so you call your stroke code. His exam is otherwise normal. His blood work's fine. And after he comes back from CT scan, you examine him with the neurologist, and he's completely normal. And he asks you, "Hey doc, I'm feeling better. Can I go home?" And I think TIAs to me are one of the most rewarding things that I do in my job as an emergency physician. And I hope you guys will feel the same way sort of after listening to this talk. And it's amazing. You really, you can prevent catastrophes. And you might not even know, what a great job you're doing because, there's no cool story to tell. Like you didn't intubate them, it wasn't like you don't have a crazy airway story. There's no like adrenaline firing procedure, but you're preventing a catastrophe. You're preventing this beautiful brain here from turning into this horrible brain here. And you guys can imagine all the devastation and sort of life-changing problems that go along with, with this second CAT scan here. So what is the risk of recurrent cerebrovascular events after a TIA? And it can be pretty significant, depending on your patient profile and your risk factors. It can be anywhere from 3 to 10% in the first 48 hours. And that's pretty darn scary. You guys may have heard of the ABCD squared rule: age, blood pressure, clinical symptoms, diabetes, and duration. This was an old prediction rule to risk stratify patients. The thought being that if you have moderate to high, you have higher risk. And if you don't have any of these, or if you have low score, you have low risk. What I want to stress to you guys is that you should not be using the ABCD2 rule to send patients home from the ED. And this rule has wide confidence intervals. Different studies were not able to basically replicate these findings. And the two biggest diseases that portend a recurrent cerebrovascular event are AFib and carotid disease. And this tool does a very poor job in determining which patients have those problems. So do not use ABCD to send your patients home to sort of defer a workup. Newer rules are the ABCD3 rule, which is essentially the ABCD2 plus dual TIA symptoms, and the ABCD3I, which is basically the ABCD3 plus MRI and carotid imaging. The old school definition of TIA was a neurodeficit that lasted less than 24 hours. The problem with that definition and why we changed it is that when we actually did MRIs on these patients, we found that a decent number of our TIA patients with normal neuro exams actually had strokes. And if you look at this study from many years ago, from 2009, patients with the the smallest duration of symptoms in TIA, a third of those patients actually had stroke when we did the MRI. So the current definition is a tissue-based definition. So basically a brief episode of symptoms that are focal and they resolve, and there's no evidence of infarction on imaging. So how do we see if there's actually infarction? Unfortunately, we need to do an MRI in these patients. So are these just pretty pictures, or do they actually mean something? Are MRIs important? So this is a famous painting from the Sistine Chapel by Michelangelo, the creation of Adam. And there's actually an Easter egg in this painting. And if you look over here at God, it actually is a brain, right? And you can see sort of the cerebral cortex here, the optic chiasm, the pituitary stalk, and the brainstem. So are they just pretty pictures? Actually, no. If you have MRI positive lesions on your MRI, that will portend potentially bad outcomes for your patients. So DWI positive lesions basically doubles to quadruples your risk of subsequent vascular events. And those events are going to be caused by high risk mechanisms that you can potentially prevent. So they're not just pretty pictures. So how do you go about reading an MRI? So let's talk about that. And hopefully by the end of this brief discussion, you'll be able to tell the difference between this picture versus this picture here. So the money for MRIs for stroke is the DWI. And I think the hardest thing about reading an MRI is figuring out what your hospital calls each image sequence, because every hospital has some different name for them. So for stroke, you're going to look for the DWI or the B1000, or if you can't, the ADC. So the DWI or B1000 is going to look like this here. And this looks for basically lack of water movement or restricted diffusion. And this very early on will be positive for stroke. So within 10 minutes of stroke, you should start to see something on the MRI DWI. And on the DWI or B1000, it's going to be sort of bright white. And this is sort of an obvious stroke here. You can see in the left MCA distribution. If you can't find the DWI and have to look at the ADC, it's the reverse here and it's black. So let's look at some pictures. Okay. All right. Normal, 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 normal. Okay. Here we go here and we see, not normal. Low white, low brightness here. So this patient unfortunately has a pontine infarct. And this is sometimes referred to as the light bulb sign because it's bright white. All right, here, the first image we're looking at, we don't see any brightness. But here, looking on the right, we can actually see a little tiny dot in the lacunar infarct here. And that's a stroke. That's all you need, right? And it's small, and that's why the patient, you can't really tell on their neuro exam. But that means that something real is going on. Things like the flare or the T2 will not show up till a few hours later. So flare or T2 will actually show signs of infarction 6 to 12 hours later. So you can help use that to predict the time of the stroke. And the T1, it can take days for it to show up. Sequence-weighted imaging is where you can see hemorrhages. So here we have a pretty nasty looking non-contact CT, which looks like a stroke, ischemic stroke. But when you actually look at the MRI, you can also see some areas of hemorrhagic conversion as well. So DWI MRI is troponin for the brain. Is there a stroke? Yes or no? I'm feeling better. Can I go home? So here are the things that I would quickly make sure before I determine whether the patient can go home. Are there high risk scenarios that are present? So any neuroimaging problems, any persistent symptoms, the patient needs to stay. Any suspicion of AFib, whether in their history, their EKG, or palpitations in their history, their EKG, they gotta stay. Cardiac disease, valvular disease, prior MIs, social problems, drug abuse, they have to stay. Dual TIA. So this, I'm going to end on this one because I know my time is running short, but I really want to sort of hit on this because this is something I really didn't appreciate, as a resident or even an attending, is how sort of risky a dual TIA is. So much so that these patients are basically excluded from all the like ED observation studies. So this is something I really want to make sure that you ask your TIA patients, has this happened before? Is this something that has occurred? And if so, this is a problem. This is a high risk, lesion that the patient should not be, sort of sent home with. Usual suspects, AFib and carotid disease. Your workup should focus on these two processes. And finally, patients should be started on an antiplatelet agent. Whether you're going to, I like to start aspirin. Whether you use dual antiplatelet agents is sort of something you should discuss with the cardiologist. With the neurologist. There's some data suggesting that dual antiplatelet agents are better, and the most guidelines sort of hint to this, but this is not something I'm currently doing on my own. So our patient, were able to convince them to stay for the workup, and their MRI showed a small lacunar infarct, and they were admitted for further workup and were found to have AFib. So TIA takeaway points: don't use ABCD2 to determine low risk. Your ED workup should look for AFib, carotid stenosis, and stroke. You're going to want to image. These patients are OBS-ready candidates, and start aspirin. And I'll open up for any questions. Or James, you want me to tell my story first, or how would you like me to proceed?
Sorry, Ron, you said.
All right, I'll give you my story. So I think back to probably my best day as a doctor was the last day of my NICU rotation at Kings County. So it's the last day, sort of getting early in the morning, and we go to delivery, and normal dates, delivery, and baby comes out, has a cord wrapped around, her neck, a few times, has a low APGAR score, is not doing well. So we, immediately, resuscitate the baby, feeling, slow pulse. So, immediately start chest compressions on the baby, begin to bag the baby, and 5 minutes later, the kid is doing, great, and, APGAR's improved, and, I'm feeling like, $1 million. So come back and, and get ready to, to begin our rounds. And, there's another call. There's going to be emergent C-section. And it was, a young patient who unfortunately did not, receive prenatal care, and she didn't know she was pregnant, but they determined that she was pregnant, in the ED, and they swooped her up for a precipitous delivery. So they guesstimated that the baby was going to be preemie, 28 weeks. So we were planning to intubate and give surfactant, and I remember so many mentors sort of there at Downstate. Too many mention sort of stressing how how critical it is to always sort of be prepared. So have my laryngoscope set up, I have my suction set up, and I have my tube set up, and always set up more than one tube, and be ready for anything. That sort of the ethos that Dr. Doty and Lucchese and Dr. Sue and Dr. Sinnert and Dr. Rennard and Silverberg and Palladino and Holt, and everyone sort of stressed on me. So we're ready to go, and they deliver the baby, and the tube goes perfectly, right? Just boom, boom, in, and, you know, we're bagging the baby ready to go. And then the, you know, the obstetrician says, hey, there's another one in there, you know, sort of just like, you know, like the movies from way old. So, you know, I have I got my laryngoscope, I got my second tube, and I'm ready to go. And there you go. It's in, and just sort of, really sort of, you know, that was a, you know, incredible, that was probably one of the best days that, you know, me being one of the best days, even looking back as an attending, me being a doctor, was from that. And I'll sort of just end up, you know, with the second thing is, you know, you guys are I'm so proud to be, you know, an alumni of this, you know, department, and see what you guys had to sort of go through. I'm so very, very proud of you. And, you know, I remember, you know, EM, you know, we're not just leaders, you know, in the field of emergency medicine. Our graduates have made strides in critical care, you know, in palliative care, in, you know, public health administration, social justice. You know, we are leaders, and not just in the field of emergency medicine. And it's, you know, these are trying times, and the world is looking for, you know, for leaders. And I say, you know, congratulations to you, class of 2020, and get out there and keep chopping. And with that, I say thank you for allowing me to speak to you guys today.
Okay. Does anyone have any questions from the audience in person? Let me just see if we can do this. All right.
I'm not sure if you can see me. How are you?
Hi, Dr. Lucchese.
Thank you so much. That was, you know, absolutely fantastic, and you know, we expect nothing less. But besides, it's very obvious that Brian Wright is a very brilliant person. But what you might not know is that he's a very level, calm person, and I never saw him get frazzled either with a consultant or with a very critical patient. I never saw him raise his voice. He's just that controlled, and I'll always remember that about Brian. He probably comes from being a lifelong diehard Yankee fan. That's what happens. So thank you so much, Brian. It's great to see you.
Thank you, Dr. Lucchese.
Any other questions from the in-person audience? Anybody at home want to unmute themselves or have any comments? I guess I had a quick question. Brian, you mentioned observation. Is this primarily at Stony Brook done through the observation unit, the TIA workup?
We primarily do it in the, you know, in the ED, and depending on our availability, we'll sometimes we obs you in your ED bed, and sometimes we obs you in our observation unit. So yeah, that it's very, very rare now for you know, for a stroke patient to be or a TIA patient to be admitted unless they have high risk features.
Okay, so they get the MRI primarily as an ED patient usually.
Yeah, we've gotten it where we can get the MRIs pretty quickly from the ED.
Okay, cool. Thank you very much. And just again,
I have a question if we have time.
Yeah, definitely.
Hi, this is Angela. I'm one of the third years. Can you comment on how the scores for LVO, how they perform on posterior strokes, and like what the role of thrombectomy is for that?
Yeah, I would imagine they do not perform pretty well for posterior strokes, and there's not really equipoise for like not doing thrombectomies on posterior strokes. So you can't use these to rule out posterior strokes. But the good news about posterior strokes is they usually look pretty bad. I guess with the exception of cerebellar strokes. So you can't use these. The bad thing about posterior strokes is that MRIs are also not that good early on for posterior strokes as well. So if you're really concerned with someone, early MRIs are bad. So if you're really concerned about someone that, you know, their exam doesn't point to a peripheral cause of vertigo, for example, then I would definitely get neurology involved and maybe consider doing a delayed MRI in those patients. Because, you know, for some MRI, like earlier MRI studies, maybe only 80% sensitive for posterior strokes early on. So excellent question.
Thank you.
Interesting you mentioned ABCD2 on that also, because there was a study that looked at patients with posterior stroke, and the patients with the highest ABCD2 scores had like a 30% correlation with posterior stroke. So you can use it as kind of like a risk assessment of somebody's likelihood of having a posterior stroke if they present with those non-specific posterior symptoms. So it may not be good for determining whether they have to stay, but it could help you, understand somebody's risk for a posterior stroke.
I think the ABCD2 score is really good for, like, you want someone admitted and you're getting pushback from, your neurology colleagues, and then you can use it in that regard to say, hey, this is pretty, similar like to like a lot of syncope scores, right? They're not really good for safely sending people home, but they're good for saying, hey, this patient's pretty risky. You need to take this seriously.
Okay, thank you again, Dr. Wright. We really appreciate you being here.
Congratulations, class of 2020.